Good evening, everybody. Thanks for being here. This is an event that Packard puts on most years to recognize Eating Disorder Awareness Week. I'm this fellow here, James Locke, who's been here at Packard for about 24 years, 25 years. Thea and I came at the same time. And I'm a professor here, and I'm the director of the Psychiatry Eating Disorder Program. And we're going to talk tonight about avoidant restrictive food intake disorder. And there's 3 talks. The first one is just a review of what it is and some work we've been doing about treatment. And then we're going to hear about the medical complications from Dr. Kapan. And then we're going to hear about a case from Dr. Rose Anya. In our about 20 minutes, I'm going to talk about these 3 things. What is ARVID? It's not a bug. It's a strange sounding thing. And what are we learning about how families can help their children with this kind of problem? And then some next steps. First, although the problems that we recognize as falling under this category of avoidant restrictive food intake disorder have been with us throughout time, it was not a specific diagnostic category in the Diagnostic and Statistical Manual of Mental Diseases until 2013. And it was quite controversial, actually, putting it in there at that time. But the problem was too many kids with eating problems didn't have a box to put them in. And when you don't have a box, then people don't know what to do. They don't know how even to think about things very well. So it was a box called Eating Disorders Not Otherwise Specified. And as a result, treatments weren't specified. And that's a current problem, as you'll see when we talk a little bit further here. But it is the first step is actually defining a problem. And so defining this entity, as complex as this definition is, was a first step. That was almost 6 years ago now. And you'd think we might have made a lot of progress, but alas, we have not, as you'll see. First of all, the main diagnostic features are it's an eating or feeding disturbance associated with failure to meet nutritional or growth needs and energy needs. And it leads to things like weight loss, growth delay, nutritional deficiencies, dependence in the worst cases on enteral or oral supplements. And it's also associated with some kind of psychosocial difficulty. It's not explained by a lack of food. It's not explained by cultural practices in terms of eating practices. The distinguishing feature between ARVID and, say, anorexia nervosa and bulimia nervosa is that with ARVID, the person does not report or experience weight or shape concerns. So there are no cognitions about appearance that are associated with this disorder. And these symptoms don't occur in the context of another eating disorder or can be explained by a medical illness. Although often there are medical illnesses that are associated with this. There are 3 main groups. Now, these 3 types of ARVID are not, at this point, truly known to be subtypes, but they are syndrome-like versions of ARVID. One is a kind of almost lifelong disinterest in eating, just no enthusiasm for it. Usually starts early, very early, maybe even with an inefficient suck at the breast to just really preferring to do anything else but eat, starting very young. Another is a sort of sensitivity, a high sensitivity to tastes or textures or flavors or smells or even colors of food. These kinds of sensitive, food-sensitive people are just highly attuned and pay a lot of attention to these elements of eating, and it often leads to a highly restrictive set of eating. I often call these the white food eaters. They eat white pasta with, rolled up Wonder Bread, Cheerios, very, very bland, very, very whitish foods. The one version, not a serious version, is picky eating. It's not just picky, it's beyond picky though. And then there's one that's fear of consequences of eating. And this one usually is a type of ARVID that follows from an aversive event. Usually they've been eating fine in their lives up to this point, but something happens. They have maybe an allergic reaction and they choke, or they have an experience of choking on some kind of food, or some medical procedure that causes them to choke, or they can be medically ill, for example, and start vomiting, and then dislike that experience so much that they stop eating. So they're afraid of eating. So this is fear of consequences. So this one is shorter term, and it's associated with fear. So if you kind of think about it, one's lack of interest, one is sensitivities, and one is fear. So these three main types. We don't have much information on the epidemiology, meaning what the rate of occurrence of ARVID is. Now that it's been named, every clinic, eating disorder clinic that I ever have speak to now is having a rash of reports of these kinds of patients showing up at their doors. And again, having been in this business for a long time, we've seen them all over many years, but now that there's a name, more physicians are referring for treatment, which is probably a good thing, but it means we really don't know much about the real epidemiology. This rate, 2 to 8%, hard to know. There's some risk factors that are associated with ARVID, neurological or muscular disorders, ASD, autism spectrum disorder, attachment disorders, and social anxiety disorders are all risk and associated things. Unlike, say, anorexia or bulimia, which have a high gender preponderance towards women and females, ARVID is an equal opportunity eating disorder. It occurs, if anything, slightly more commonly in boys. Again, comorbidity, even when you have not just a risk factor, autism spectrum disorder, anxiety disorders, ADHD, and intellectual disabilities are all common things that you may see associated when someone presents with ARVID. There are no adequately powered studies available to guide clinical care. There are none, which is really challenging for us. Approaches that people have tried, and there are some case studies of and case series of, are behavioral therapies, various forms of family therapy, nutritional therapy, enteral feeding, which is using a line, cognitive behavioral therapy, which is currently under study, and occupational therapy, which is usually about helping people learn to swallow or practice swallowing and eating. These are all strategies that are used clinically. Data about even preliminary data is pretty slim on their effectiveness. Partly because the most serious cases are treated in hospitals, where protocols are not well established across sites anyway. And only more recently have outpatient treatments been more systematically developed. There are two that are cognitive behavioral therapy, and I'm going to talk about family-based treatment. So my work over the last 20 years has been looking at how families can help their children with eating problems. And over that time, we've demonstrated that family-based treatment, which is a family in which parents are helped to learn how to manage eating problems in their children, like anorexia and bulimia, has been shown to be effective for It is the first-line treatment for anorexia nervosa now worldwide for adolescents and for bulimia as well. So over this course of 20 years, we've been able to demonstrate that it's an effective and probably the most effective treatment currently available. And family-based treatment involves helping parents learn and use effective behavioral management techniques, employing their skills as parents and their knowledge of their family and family routines. It's not focused on cause and doesn't use any kind of content, cognitive behavioral content, meaning looking at thoughts. And that's pretty important as a reason to think about it. It may be very particularly useful for ARVID, where there is no content around appearance and shape. So it might even be better for them than it is for anorexia or bulimia. Hard to know. There's some differences. We have adapted family-based treatment for ARVID, and we published these adaptations just recently in the last few months. So all this that I'm talking about tonight is really very, very new information, like in the last 6-8 months. One of the big differences between ARVID and anorexia and bulimia in adolescence is that the first two types of ARVID, loss of interest, lack of interest, and food sensitivities usually are lifelong things. They start early and they are maintained. Whereas for anorexia nervosa or bulimia nervosa, these things usually onset during adolescence, and there haven't been a lot of eating problems prior to that. There may be some, but not a lot. It's not the most common thing. So one big difference is these have already, in the first two types, been long-standing problems that the family's been trying to cope with, usually not very effectively or successfully, using with a lot of frustration. And so that's a big difference in the starting point. For the fear of consequences, that's more similar to anorexia nervosa in the sense that fear is a big part of it, as it is in anorexia, and also it's shorter term. So we did a little study because this is how you start trying to find treatments that will help. We wanted to know if this new version of family-based treatment would be helpful. So we looked at children with ARVID, all three types, who were between ages of 5 and 12, and they either got whatever they usually did, whatever therapies or not therapies they usually did for 4 months, or they got FBT ARVID. We were really mostly interested, would this be a treatment parents would accept? Would they stay in treatment? What would the outcomes be in a preliminary way? The disorder, again, is so new, even evaluating outcomes is a challenge. This instrument called the PICA ARVID Rumination Disorder Interview, or the PARDI, that instrument's psychometric properties have just been published in the last 6 months as well. So even the outcome measures that we would use are so new. So we were interested in that. And the other thing we were interested in, could we change how parents felt about their abilities to manage this problem, their so-called self-efficacy. We had seen this change in parents with anorexia and bulimia in family-based treatment. And this is an important strategy for likely understanding why there are changes as a result of the intervention. So just in brief, FBT for ARVID uses a non-blaming strategy for the patient, for the parents, for entire family. It's not looking for familial etiology. It's actually trying to see the illness as an illness and to treat the illness as the problem, not the patient as the problem or the parents or the family. And the idea is to help parents learn better ways to manage the problem of the child's eating, and doing that by improving their sense and ability that they can do it, and targeting specific strategies and outlasting the symptoms. And this What this means is you would be setting up essentially a change. You're changing your family environment so that you're actually addressing this problem rather than avoiding it or accommodating to it, which is usually what has happened over years of these things. There are slightly different versions of FBT for lack of interest and sensitivities and fear of consequences, but we don't need to get into that this evening. So we screened 40 people. 8 of them weren't eligible or weren't interested. We did baseline assessments on 32. Of those, 32 enrolled, 28 were randomized, 16 in ARVID and FBT ARVID, and 12 in usual care. So it's not a big study, it wasn't meant to be. So the kids were about 9 years old. They were about half girls and boys. They had depression, they had anxiety disorders, they had ADHD, some OCC, obsessive compulsive disorder, some autism spectrum disorder. Pretty much what I said. This is pretty much a representative group from what we would expect clinically for an ARVID group. The race and ethnicity numbers are pretty similar to what we have in our clinic in general. And it was surprisingly easy to recruit people for a new disorder. The overall dropout in the study was about 20%, which is pretty typical of studies. And on a scale of 0 to 8, pretty much people thought the treatment would help them, and there were no adverse events during the study. What I really want to show you here, and this is just a complicated slide for people who aren't really in the business of things, but something called effect size. What that means is how big a clinical impact did the intervention have? Not statistical number, but clinical impact. And numbers 5 and above are pretty good, 0.5 or above. So you can see here that on weight, 0.87, that's good. On the severity scores, again, 0.83, and changes in the subscales are harder to read because because the whole sample didn't have high scores on everything, so you couldn't really use those the same way. But what this shows you is a couple of things. One, kids did well. The severity of their eating disorder went away, improved, and their weights improved. This is just an example. Really, this is not clearer. The kids in the usual care is that gray line, and the red line are the kids who got FBT ARVID, and there's a big difference in those two, almost twice as much. And severity on this measure of ARVID's psychopathology or worry and concern, again, the light gray line is people who were in usual care, and then the group that were in FBT ARVID, and again, very big effects in terms of clinical impact. And this one tells you about parents. This is parents versus ARVID, which means basically parents' health efficacy score. And there was no change in the usual care. Parents who were in usual care had no change in their sense of being able to manage this problem, whereas there was a dramatic improvement in the group that got FBT ARVID, which we would expect given the things that we saw. And this was a significant effect. So what we're trying to show you here is that we have a hope on the horizon that this treatment is feasible to do. Parents and kids learned and got better using it. This is for children in the school age years, whereas ARVID is a lifespan disorder. Younger kids have it, and adolescents and adults have it, so it's limited by the fact that we looked at school age kids. The outcome measure is new, and it's only one, so we need to, that's a limitation. And these were people who were seeking treatment, so these were not people who, so they may have been dissatisfied with usual care to begin with, so that's important. So just in conclusion, it may be that we will have transdiagnostic treatment that works for anorexia, bulimia, and ARVID with FBT, which would be really great because it's a single treatment and people who work in the field could learn one version of care and apply it across the spectrum of problems. We've submitted a grant now to get large enough studies funded to actually see whether or not we can prove that this really works better. That takes a while. One of the hardest things about working in research is how long it takes to go from an idea to actually something that has demonstrated effects. But patience and persistence is the hallmark of what we have to do as researchers. And so I'm, as I say with my families I work with, I'm patiently impatient with anorexia. I'm also that way about research. So I think we're on a good footing to start moving forward on this. To sort of put a little bit of more texture around ARVID, I'd like to introduce Dr. Kapan. Dr. Kapan has been here for 25 years too, so I don't know how that could be since that doesn't seem possible. We used to have our unit in this hospital on the 3rd floor, 3 South. I think it's now a cardiac wing. It was kind of a cardiac wing even when we were there because lots of bradycardia. And Dr. Kapan is one of my oldest colleagues, friends, and great. We're so lucky to have her here, and the kids are so lucky to have her here. The attention she pays, the passion she brings to this work is unmatched. Thank you, Thea, for being here. Thank you.
So I am really glad to be here talking with you about the medical issues related to this. So when kids come into our program, kids and teens, they come through the child psychiatry department, and in general, we do very comprehensive evaluations of these children and teens that come to see us, focusing on both the emotional issues that are happening, the psychological issues, and then the nutritional issues and the medical issues. And with the ARVID kids, we have a little bit different approach to those kids. Many of them need all of our services, the medical and the nutrition and the psychological ones. There's actually some kids that come in that are more having the psychosocial impacts of ARVID and may just see psychiatrists. So I'm going to be talking to you more about the medical issues and sort of looking at some of the kids that might end up in either category where we're very concerned about them medically or maybe more worried about them socially and their impact of ARVID, but not so much medically. So are children and teens with ARVID at risk for medical complications? Well, it really depends. By definition, ARVID is impacting people being able to meet their nutritional needs or energy needs. But as Dr. Locke talked about, there's basically 4 ways that you might see that manifesting. One is that there's significant weight loss or a failure to gain weight or grow adequately. There might be significant nutritional deficiencies. People might be dependent on enteral feeding or tube feeding or oral nutritional supplements to meet their nutritional needs. Or there might just be marked interference with psychosocial functioning. So you may be getting enough to eat and grow, but you may not be able to go out with your friends and have pizza or go to parties or go off to college and be able to have a normal, balanced social life there. So any of these 4 things might be a way that you could be categorized as having ARVID. The last 2, if you're not getting enough nutrition in your diet, but you're making up for it in other ways, or if it's just affecting you socially, those things are really significant from an emotional standpoint, but may not necessarily impact you medically. But the first 2, if you're having weight loss or not gaining weight or growing adequately, or if there's some significant nutritional deficiency because you're cutting out particular foods or food groups, those are the kids that I'm going to be more involved with their care because we're going to be more concerned about the medical complications with those kids. It also depends on the age and developmental stage when the food restriction occurs, whether there's going to be medical complications related to that. A lot of times, the patients that we see with ARVID are actually at the younger end of the spectrum. So average age is about, it's not uncommon for the children to be presenting at age 12 or younger. And you compare that to patients more with anorexia or bulimia, those tend to be presenting more during the teenage years. So when you're a younger person and you have eating issues, on the one hand, we get more concerned about growth and developmental issues because it's such a critical time. On the other hand, there's some opportunity with that, though. If you have somebody that's presenting at a younger age and you catch it early, there's a real opportunity to, if you're able to intervene and get people on track with their eating, that you can get catch-up growth, that they can develop and become a healthy, normal teenager, and really shift gears once their nutritional has improved. We also see that the risk for medical complications depends on the time course of food restriction. Dr. Locke talked about some of these different ways that it can manifest. Sometimes we'll see people that have a sudden decrease in their intake and their weight. So if they've had one of the episodes of choking or they've been ill and then they've really decreased their intake after that, those tend to be the people that we see that are more likely to have complications with their vital signs. So low blood pressure or low temperature or low pulse. Another group of the kids, though, it's more gradual and maybe more insidious, where they're just over time not getting really the nutrition that they need. And those kids are probably more likely to be missed because it's more, there's not anything dramatic that's happened. Today is not different than yesterday or last month, but over time they're not getting the nutrition, and that might really impact their growth and development. It also depends on what foods or food groups are being avoided. Some kids are getting foods from different food groups, but they're kind of particular about those foods. Other kids are really eliminating whole food groups, and that has a different impact on the child. And then also it depends on, even if these people are not getting nutrition from particular types of foods, if they're meeting their nutritional needs in other ways. When we look at, somehow my top of my slides got cut off, but if you're comparing sort of the more typical, sort of classic eating disorders, anorexia or bulimia, to ARVID, we see a difference in the body image disturbance that Dr. Locke talked about, but also the reasoning behind the eliminations of the food. For people that are restricting eating with anorexia or bulimia, it's more to control their weight. With the children and adolescents with ARVID, it's more because there's something about the food. Either they're getting stomach pain, they're nauseous, they're afraid of choking or vomiting. There's some sort of strong taste or texture that they're reacting to. The preferences also are different, and it leads to a different pattern of foods that are eliminated in the diets for the different kinds of eating disorders. So for somebody with more anorexia and bulimia, there tends to be good or bad foods or healthy or unhealthy foods. It's not uncommon for people to migrate more towards being vegan or vegetarian or gluten-free. And a lot of times there's a preference for fruits and vegetables and avoiding fats, carbohydrates, or high caloric density food. See quite the opposite, generally with children with ARVID. A lot of times these children are actually preferring more processed foods or things that contain higher amounts of fat, so chips, ice cream, chicken nuggets. A lot of times they've targeted a particular brand, so it's not just peanut butter, it's that brand of peanut butter or that particular burger from that particular restaurant. And Dr. Locke talked about the sort of beige diet, these foods that are bland and neutral and tend to taste pretty much the same each time you pick up a cracker. And then, if anything, though, children with ARVID and teens with ARVID tend to be shying away from the fruits and vegetables. So that's a category that's often missing in their diets. So when you look at the selective eating that you see in ARVID, you have an inadequacy, potentially of variety and the amount of foods, but it doesn't necessarily mean that people are insufficient in calories. So you may have somebody that's eating a couple of tubs of ice cream. They may be getting plenty of calories, and they may be growing adequately from those calories, but they may be not getting the kind of variety that they need in the nutrients from what they've selected to be eating. If you see somebody, though, that's not getting enough caloric content to be increasing in weight and it's impacting their growth, then we're concerned about malnutrition in those individuals. You can see people that are malnourished at normal weights, at overweights, and at underweights. So you can't just look at the weight status of somebody alone. Potentially somebody who's very selective in their eating may have problems having a balanced diet and may actually be overweight because of that. You can be low weight from the malnutrition or be at a normal weight and be inadequate in your nutritional, in the nutrition that you're getting from that. When you're avoiding whole food groups, your micronutrient intake might be decreased. So vegetables.
Road, Menlo Park, and 9280 North.
For vegetables in particular, fiber is important. So people who are avoiding vegetables might not be getting enough fiber in their diet, as well as some of the vitamins, folic acid and potassium. Fruits, vitamins also important with that. Dairy products can be an important source of calcium. You can get calcium from other types of foods, but it's fairly easy to absorb in dairy products, and so children who are avoiding that can have difficulties with their intake of calcium, and also vitamin B12 is found in animal products. So that might be deficient in kids that are avoiding animal products. Meat and poultry, fish, eggs contain iron, vitamin B12, and some of the other elements. So children that are not eating those food categories could be deficient in those areas. Grains have a lot of B vitamins in them. And fats and oils, they're important for the fats and oils themselves, but they're also important because they help our bodies absorb, we call them the A deck vitamins, so A, D, E, and C vitamins. So when you have fats in your diet, it helps you be able to absorb these vitamins. And so somebody that's avoiding those things might be deficient in some of these vitamins. So whether you're not getting the proper micronutrient or not, it may or may not lead to medical difficulties. It has to be fairly extreme for us to actually see clinical evidence of somebody that's deficient in this. We do see a number of our patients that are deficient in vitamin D, both in all types of eating disorders, anorexia, bulimia, and in ARVID. We also see a number of kids that are anemic and are deficient in iron as well. So those are the two main categories of things that we pick up in our clinic. Evidence does suggest, though, that in adulthood, if you're really eliminating full food groups, there might be issues with that. So people that, for instance, are avoiding fruits and vegetables, they have potentially a higher risk of morbidity from heart disease in adulthood, some cancers, potentially some metabolic diseases, and overall risk of death. So the bottom line is it's great to have a diverse diet, and it's hard for people with ARVID, particularly if they're avoiding whole food groups. So the medical complications that we see in people that are not getting adequate nutrition, if somebody's not getting enough energy from the foods to meet their needs, the body adjusts to this. So just like bears go into hibernation when it's winter, our bodies do the same thing. And it's a protective mechanism. So the heart rate goes down, the temperature goes down, the blood pressure goes down. It's a normal adaptation to being nutritionally deficient. It's not healthy, it's not good for somebody, but it's the way that our body gets through and survives. And when you think about being in survival mode, you want your brain to be going and you want your heart to be going. Everything else is kind of extra. So the gut slows down, particularly hands and feet. You don't really want to be sending a lot of blood to your hands and feet. So oftentimes people will get cold hands, cold feet, not a great blood flow from there. And it's all the way that the body's really triaging. It's saying you got to keep the brain going, got to keep the heart going, and focusing the efforts into that. And then in particular, you certainly don't want to be growing taller, and you don't want to be having a baby or getting somebody pregnant if you're not getting enough nutrition. So it's so important during teenage years to be growing and developing and going through puberty. That really gets put on hold for somebody when they're not getting adequate nutrition. The effects on the heart are the ones that we get most stressed out about on an acute level, mostly because it can be a potentially serious or lethal complication. The low heart rate is not a sign of fitness. It's a sign that the body shifted into hibernation mode. We see low blood pressure, drop in blood pressure. We call it orthostatic changes when you go from lying to standing, and the heart either races fast to try to get the blood circulating or the blood pressure drops with that. And then potentially we can even see abnormal heart rhythms that can be even fatal, or heart failure. The chemical messengers of the body, the hormones, are also really impacted by malnutrition. And eating disorders suppress these hormones, and particularly the ones that are needed for growth and development. We see puberty stopping and not going through the normal stages at the appropriate ages that we would expect that. For girls, the ovaries can shrink, and you have loss of menstrual cycles or not starting your menses at the time that you'd be expecting with that. And boys as well can be affected. So their testicles shrink. If they have gone into puberty, they might lose their erections or loss of libido with that. And some of these hormonal effects can potentially be irreversible if they're not addressed and gotten on track with your nutrition. So during the teenage years, it's a really critical time for building up your bone mass. And if you're not able to do that during your teenage years, then in adulthood, or even during adolescence, you might be more likely to get fractures and have osteoporosis. And then also growth retardation and short stature can occur as well. I don't know if I've got I do, oh, I've got this little thing. So with growth and development, if you look at this axis is age in years, and this is the percent of final adult mass. So infancy to the start of adolescence here, you see a lot of growth is happening during the teenage years, during this time here. Practically all of your genital growth, your pubertal development happens during the teenage years. About half of your general growth happens during the teenage years. Your brain doesn't change a whole lot in mass, but it changes a lot in the connections and in the function of the brain. So this is a really critical time of life for growth and development. About 25% of your adult height happens during puberty. Your heart increases by double in its mass during puberty. Your bone mass increases by almost 50%. And actually the body percent fat is actually important as well. When your body has enough of the percentage of fat, it's a signal to your hormones that it's okay, you can go through puberty, you can start reproducing when it's the right time to be doing that. And so your body's sensing that as well. And in a normal adolescence, they need to go through smaller percent body fat in early adolescence to adulthood, when for females at least, it's about 27% fat mass. And then the brain, even though it's not increasing in mass, there's a lot of connections that are happening and pruning that's happening throughout adolescence. By the end of the growth spurt, about 90% of the adult bone mass is established, and we kind of consider it like a bone bank. So during adolescence, you can put money into the bank, you can take money out of the bank. Once you get to be an adult, you kind of have your bank account. You can take money out of the bank, but you can't keep putting money into the bank there. And we see about half of our patients with eating disorders, not just ARVID, have issues with bone mass and decreased bone density. We see it in girls and boys. We see it in people that have normal weight and disordered eating, not just in people that are underweight. And it comes both from an inability to deposit the calcium because you don't have the proper hormonal signals for that, but also for kids that are lacking in dietary calcium. You can't make up for it, though, by having lots and lots of calcium. You need those hormones to be able to direct the calcium to the right place, and that takes you being nutritionally in a good place for the hormones to be working properly. We see a lot of gastrointestinal complications as well from malnutrition, and this gets to be kind of a vicious cycle because when you're not getting enough nutrition, then you get constipated, you get bloating, abdominal discomfort, and then you feel crummy, and then it's harder to eat, and then you lose more weight, and then it slows down even more. So it can really be a cycle that spins on itself in a negative way. We also potentially can see some liver effects from starvation and from refeeding. It's very common in kids with ARVID to see GI symptoms. And there was one study that was done of an eating disorder program that was adolescent medicine based, and they found that about a third of the children, or the teenagers, had abdominal pain. About a third reported that they had decreased appetite. About a quarter were afraid of throwing up. 21% said that they felt full, and 18% reported nausea. So it's such a difficult situation because you have people that are malnourished, and yet they're reporting all of these symptoms, and you're trying to get them renourished again. But it's also important because that's actually ultimately what can help them feel better from a GI standpoint. A lot of these patients also present to different specialties besides to adolescent medicine or psychiatry. Sometimes they've had a very circuitous path before they arrive on our doorstep. It's not unusual for them to present to gastroenterologists, potentially to endocrine doctors or other people before people identify that it's actually an eating issue. The brain is also very much affected by malnutrition. On your left here, we have a normal brain. White is good. So white is lots of brain tissue. So when you have a normal brain, you have lots of dense neurons that are connected well. And when you see somebody who's really malnourished, what you end up with is the black space is fluid-filled spaces, and the white tissue is diminished. So you actually have loss of brain tissue and an increase in fluid-filled areas. And also there's a loss of the richness of the nerve connections in people that are significantly malnourished. And what we see in clinical practice in patients, if they're admitted and they're significantly malnourished, we actually can see in our interactions with them that their brain's been affected by that. There's something called organic brain syndrome, and it's just the thinking is slow. They seem kind of stuck with their thinking. They have trouble concentrating. They might have more difficulty in school. Ruminating, being sort of stuck spinning in their thoughts, difficulty with even basic decision making, or might even report some short-term memory losses. Many of the children and teens that have this really don't have any idea that they're exhibiting these symptoms. It's more us looking at the outside and seeing that there's a difference. And then even sometimes in a short time, if somebody's in the hospital, if they've come in and they've gotten better nourished, we see a change in their thinking and their ability to relate to us and interact, and their thinking is more. I put the picture of the hamster in because a lot of times in the beginning, I just feel like you're talking to somebody and they're just spinning around. But by the end, you see an opening of that thought process. And it also helps them then be able to engage more in the process of refeeding and some of the emotional things related to that. At times, we always would prefer to treat people in the outpatient setting. That's by far our preference, to be able to have people be in their normal lives and interacting and being with their families and doing regular kid and teen things. But there are times though when it's come to a point where medical hospitalization is important for somebody. And the things that we look for with that are whether somebody has vital signs that are unstable, so significantly low heart rate, a low blood pressure, low body temperature, and orthostasis, that change from when somebody goes from lying to standing. That's often one of the earlier signs that somebody's in trouble nutritionally as well. So we check that in clinic. If somebody's really severely malnourished, they might be admitted just on the basis of that, or if there's some other medical complication, such as abnormal heart rhythm or dehydration or fainting or some other medical problem. So we're going to transition now to a great case study that Dr. Kimberly Rose Anya is going to be presenting for us.
Hi, I am Kim Rose Anya. I'm a postdoctoral fellow in clinical psychology in our eating disorders clinic. And I'm going to describe to you an example of what family-based treatment for ARVID can look like. All names and identifying information about this family has been changed in order to protect their confidentiality. So I'd like to tell you about Allison. She was a 9-year-old girl who was brought to our clinic by her parents, and they wanted help with very sensitive, selective eating that Allison had demonstrated her whole life. And parents were really very clear and on the same page with each other about why they felt like her eating was a problem. They said, we have to plan every single meal around what Allison is willing to eat. We can't travel, go to restaurants, eat at other people's homes. This was a very different perspective on the issue from Allison, who really felt like this wasn't really a problem at all. If they would just let her eat the way she wanted to, there wouldn't be an issue. So she really wasn't thrilled about being there. This was actually a problem the family had been dealing with almost all of Allison's life. They remembered that, even when she was a toddler and they first tried to introduce solid foods to her, she rejected most of the foods that they tried to present to her. They also had a really painful memory from when she was in preschool, and the preschool teacher pulled parents aside, expressing worry that Allison brought the exact same lunch every single day. Could they please provide more variety? Parents not only hadn't really realized that that might be unusual that they were sending her with the exact same thing, but they also realized that they didn't really feel like it was possible to send her with anything else. At that point, because they felt kind of guilty, like maybe they were doing something wrong, they tried sending her with more lunches, with different lunches, and they came back completely uneaten. So that didn't work. Over time, Allison's eating preferences became pretty specific to the beige diet that was referenced earlier. So her staples were mozzarella string cheese, white bread with butter, and pasta with butter. And that was it. She also developed very specific preferences about the brands. So it couldn't just be any mozzarella string cheese, it had to be one specific brand. And then lastly, she also started to develop some preferences about what the items looked like. So if it wasn't a packaged item, but rather something that could be made, like bread with butter, it had to have a very specific appearance. So for example, she was willing to eat cheese quesadillas, but there couldn't be any marks from the grill on the quesadilla, which meant that those items were then really difficult to find versions of them that she was willing to eat. Over the course of Allison's life, the family really coped with this problem in a variety of ways. Parents described kind of a constant nagging that just all throughout her life they felt like they needed to do. Meal times often were more like battles and really lengthy because they just put so much effort into trying to persuade her to just try something else or eat more of this item. They at various times tried having some sort of rewards or consequences that Allison could earn, but it was really hard for them to find any that were motivating enough or that parents were able to really stick with and implement effectively. So overall, really parents ended up just kind of accommodating Allison's preferences because it was all they could kind of figure out to do, meaning that parents just prioritized every single day finding a way that Allison would have the limited foods that she was willing to eat. This meant going to the grocery store quite frequently, going to the specific grocery stores that had the foods that she was willing to eat. It meant cooking her own dinner every single night, separate from the rest of the family. And it meant largely avoiding activities that wouldn't provide foods that she needed. So Allison wasn't really able to engage in a lot of structured out of school time activities, and the family wasn't able to travel the way they would like to because of just the difficulty of planning food. So this has been going on a long time. Why now? In Mom's words, I'm getting really tired of all the extra work. So over time, this problem seemed to be getting worse, not better, and the impact on Allison and on the family was really starting to take a toll. We diagnosed Allison with ARVID. She would fit into the category that Dr. Locke described earlier as the more sensitive, sensory sensitivity type of ARVID. And we started family-based treatment. Family-based treatment for a 9-year-old girl typically would have 2 phases. The first phase was really charging the parents with the task of taking on this eating problem. So taking over Allison's eating and really working together week to week as a team to prioritize how are they going to push against this illness? How are they going to help her actually make some changes? And once parents are able to feel empowered in their ability to manage this illness, once they're able to help Allison really start to make some changes in her eating, then we move to phase 2, which is helping Allison kind of expand those skills into more developmentally appropriate settings, like being able to eat well on her own with less parental support, being able to eat well at restaurants or on play dates, in those social situations that a 9-year-old girl might need to eat in. For our purposes, I'm going to talk a lot more about phase 1 than about phase 2 because phase 1 is where you really see some of the most important changes. In the very first session of family-based treatment, one of the things that we spent a lot of time talking about was thinking about this eating problem as separate from Allison, meaning that this is an eating problem that has come into her life. It's separate from her. It's not something that she has control over. It's not something that is her fault or the parents' fault. And it's something that she's going to need some help with, kind of removing from her life. I also spent some time really helping the family take a step back and recognize all the consequences that ARVID had already had on Allison and on the family, and the very serious consequences that it could have in the future if they did not interrupt it now, if they let this illness continue. So for Allison, ARVID was already really getting in the way of her ability to make friends and keep friends because it was interfering with her ability to do stuff with friends outside of school and on the weekends. And over time, you could envision that this is the type of thing where there could be some stigma for her about her eating habits, and this can lead to isolation over time. Also, family relationships were getting pretty strained by the topic of eating. There was just a lot of time and energy spent arguing and stressing and worrying about food. And parents were beginning on their end to start to feel really resentful and frustrated. Also, medical consequences wasn't really something the family was thinking about, but I went out of my way to really highlight this for them. Allison was mostly eating refined grains and dairy, and that's it. So nutritionally, there's potentially some concern there. And then Allison, the family hadn't really realized this, but she was actually underweight and starting to fall off her growth curve. The family hadn't realized because they'd been talking to the pediatrician throughout her life about this, these eating issues, and the pediatrician really thought, oh, this is picky eating, kids grow out of it, don't worry, keep waiting, she'll grow out of it. But what the family was really reporting was that she was not growing out of it, this was getting worse. And in fact, she was starting to fall off her growth curve. And as you just heard from Dr. Kapan, if Allison's 9, approaching adolescence, this is a really, really important time, especially to be making sure she's getting enough nutrition in anticipation of adolescence. So this was something that I wanted to highlight to the family. Thinking about these consequences very explicitly helped the family really feel a renewed sense of urgency to do something about this problem that, frankly, over many years, they had kind of just accepted and gotten used to. And it also helped them really feel an urgent need to actually take really decisive, committed action right now to turning things around. But in addition to that sense of urgency, I also really wanted to help the family feel a sense of empowerment, meaning yes, they need to do something about this, but also that they were able to do something about this. That not only are they people who know Allison really, really well, they're people who know how to take care of their daughter, but they also are probably her best resource for getting better. As you've heard, we don't actually have treatments that we can say, yes, this definitely works for ARVID, and her family it's who she lives with, it's who loves her, it's where she's growing up. And so can we help the family figure out how to help their daughter overcome this? Also within this first session, one of the things that we did was talk about some of the ways that ARVID kind of maintains itself and implications for what the family may have to do to try to disrupt it. So for example, kids who are very sensitive eaters, very selective eaters, they often have very strong aversions to any foods that are novel, any foods that are different. In Allison, this manifested, she would say, I'm so worried it's not going to taste good. So if you're really worried something's not going to taste good, what do? You don't eat it, you avoid it. Well, every time you avoid a food that's like pretty scary and that you're stressed about eating, you feel a little bit of a sigh of relief. Okay, you didn't have to eat that. That's an understandable reaction, but the problem with that is that means that the next time that food comes along, well, you're just as scared and stressed about eating it as you were the first time. And you remember that the last time you avoided it, that felt good. That was a sign of you felt relief. And so you avoid it again. And it becomes this cycle that just reinforces itself and gets stronger and stronger and stronger over time. And so it means that you never get to experience that food as something that you get used to or something you get comfortable with. It remains a novel food. It remains something scary and unknown. And it remains something that you feel pretty anxious and afraid of. And so one thing that families often have to do is break this cycle. And a way of breaking that cycle is really intentionally exposing the child to some of these foods that they are averse to, some of these foods that they're afraid of, and exposing them to those foods over and over and over, even though they're afraid, to help them not be afraid of those foods and to help them learn, this food is actually okay, I can do this. One strategy for doing that is something called food chaining, meaning that if the food kind of as it is way too scary or way too hard for the child, you can start with maybe a smaller, easier version of the food, like a baby step. So for example, if a food that a child's really, really afraid of or really does not want to touch is some sort of fruit like a strawberry, but they are willing to eat very, very plain granola bars, then rather than just go ahead and start exposing them to strawberries, you could maybe start with a granola bar with a strawberry filling and just get them used to that flavor of strawberry. And then over time, kind of up the ante until you gradually are moving towards helping them actually eat strawberries. One last thing that we did in this first meeting of FBT is help the family create something we call an always, sometimes never list, meaning helping the family really identify foods that Allison was able to eat or not eat. So always foods are foods that just reliably she could eat, no problem, those are their go-tos. Sometimes foods were foods that she used to eat but have recently kind of fallen off the list of allowed foods, or they're foods that maybe they can get her to eat if they really, really push. And then the never foods are not every single food Allison never eats, because that would be way too long, but rather foods that she doesn't eat, but wow, would they be really important or meaningful if the family could help her eat them. So those might be foods that nutritionally or medically could be really important for her. Those might be foods that are important to the family, favorite dishes that they love to serve that they can't serve anymore because Allison won't eat them. Or they could be foods that might be really useful for Allison to eat because she's exposed to them in a lot of social settings. Pizza, for example, is one that comes up a lot because if you can't eat pizza as a kid, it's really hard to be able to participate in the many pizza parties that happen. So for this family in particular, one of their greatest hopes for Allison is that she would be willing to eat entrees from the restaurants that they wished they could go to and that they used to go to before they had her. So that was kind of on their list. This is a list that we use to identify goals, help the family kind of figure out what they want to target, what they want to help her with, and it's also something that we use to measure progress. The second session of family-based treatment, the family actually brought a picnic into the office. They brought in a variety of foods from across Allison's always, sometimes, never list. And the goal of this was not only to help me as a therapist start to get a sense of family routines around meals, but also to kind of be there to coach them through parents really working together to help to really challenge ARVID. So in our particular session, Allison initially, of course, ate the foods that were her favorite foods, finished eating them, and then requested more of only those specific foods, did not want any of the other foods her parents had brought. So I challenged her parents to discuss together, what step would they like to help Allison take towards kind of pushing back ARVID. They talked about it and they decided, man, we'd really like to see her take a bite of hummus. Just a bite of hummus. Hummus is a food that we all love. Hummus is a food that we feel like nutritionally would be great for her. Let's see her take a bite of hummus. And then they then proceeded to try a variety of strategies to help her take this bite with some coaching from me. Allison, of course, was totally not having this. She started flipping her arms, turning her head. She looked away. She moved her mouth, just got really red and upset. But parents ended up using a variety of strategies that they actually hadn't quite used exactly in this way at home before. So they moved away the foods that she wanted until she took this bite. They both sat at the table with her, whereas at home, realistically, it takes her so long to eat. These battles get drawn on so long that one parent usually eventually leaves the table because they have other stuff to do. It's a weeknight. And so this time, actually, both parents were sitting there and they were on either side of her and they were staring at her. So there's actually quite a bit of pressure. They also started giving her really clear, simple, specific instructions of what they wanted to see her do. Take a bite of hummus. You need to take a bite of hummus. Which sounds simple enough, but actually normally their conversations are more like, Allison, did you just please take a bite? Honey, this is, they're really drawn out arguments. There's a lot of emotion. There's lots of different topics. There's attempts to reason with her. And so one of the things I coached them to do was to just stick with specifically what they want to see her do and use that almost like a broken record. It actually builds up the pressure quite a bit. So they were doing that. Allison was getting very uncomfortable. They kept the food close to her. So one strategy is Allison would kind of push the food away and be like, no, I'm not eating that. They would move it right back. And lastly, they also just said to her, we're not leaving until you eat this. And that was all it took. She took the bite of hummus and that was it. So they had success. And one of the things that was notable for this family is these were all strategies that they had actually tried at some point before. Like none of that stuff was new to them. But they had never really tried it together in such an intense way, all together at once and so persistently over a period of time. So parents felt a sense of success and before they left, they talked about, okay, how could they continue this at home? And what do they want to start with? What do they want to try next beyond this? They chose starting with cheese. So she only would eat mozzarella string cheese. And they said, well, let's start with just expanding what cheeses she's willing to eat. The rest of phase one was really me facilitating parents talking week to week about what they wanted to try that week, what strategies they wanted to use, what foods they wanted to help her with, and how they wanted to do it. And then reflecting also on how it had gone the week before and what did they learn from their experiences. We used that always, sometimes, never list quite a bit for ideas about what they might want to work on next. And notably, although Allison in the beginning was like, no way, no how, I'm not doing this, really wanted nothing to do with this. Once she realized that this was something her parents were doing with or without her, she was pretty motivated to have a say in what parents chose next. So she started jumping in quite a bit with her own ideas. So parents might be debating between two different foods, and she would kind of say, oh, I want this one. Over time, parents found a number of strategies to be helpful, and the ones I really want to highlight are ignoring requests or complaints that were really driven more by ARVID rather than Allison per se. So for example, before coming into family-based treatment, the family tended to ask Allison, which is really more like asking ARVID. So they would say, well, will you eat this? And what would she usually say? No, of course not, no. So they would ask her, will you eat this? No. Will you eat this? No. Will you eat this? No. That was just such a common exchange. And so what the family really learned is that rather than paying attention to what Allison said, paying more attention to what she was able to do, because her default answer was usually no, but at the end of the day, with the right support from her parents, she often was able to eat much more than she said that she would, or that she thought she would be able to. Another big piece for the parents was really prioritizing consistent execution of these food challenges. This takes a lot of time and effort and coordination between the parents. And as I said before, these were things that they had tried, but they had never really so intentionally committed to really prioritizing this day to day. Meaning, if it's been 5 minutes and she still hasn't taken a bite, can you still sit there? Or do you have to get up and go do something else? They had a younger child to also take care of too. They were both working. It's hard to prioritize this. But at this point, parents were able to really just decide this was something that needed to change. And when they were prioritizing it and really working on it, having those more frequent exposures to those novel foods really helps them much more quickly become foods that Allison got comfortable with. Something else that we did in this phase was also continue to talk about whether Allison was eating enough food. It was very clear to parents that they really wanted to help her with her flexibility and the variety in her diet. They weren't so sure about the piece of regarding under eating. And so it was just something that we continued to talk about to assess if it was anything that they wanted to intervene on. Over time, parents got really good at these exposures. They really were just taking ownership of them and running with them. And so it started being able to do so much more spontaneously and without discussing it quite as much as it took in the beginning. And Allison really started to kind of take her own initiative, her own responsibility. She started generating a lot more ideas of foods that she wanted to try. For example, she said to the parents that she was really interested in trying sushi. She thought it always looked really cool. She was really afraid of actually eating a full-blown sushi roll, but just that was something her parents never would have done on their own. So she started to really get motivated and picture things that she might want. Parents also started really being able to help Allison eat in other settings beyond their home. Some of the most exciting milestones for them were being able to go to some restaurants that they had not normally been able to go to because there was nothing that she would eat. And in particular, being able to take a vacation to a foreign country where they didn't know exactly what food was going to be available, where their grocery store wasn't going to be, there wasn't going to be their favorite grocery store there. And they were able to do it. And ultimately, they did decide that under eating and weight was something that they did want to talk about more and they did want to do something about. And part of that was that they realized it was something that, hey, maybe they could actually make a difference about. Meaning that using the same strategies actually that they had used to help Allison expand the variety of food she was eating, they thought, well, we can actually use that to try to help her make sure she's getting enough nutrition. So their idea was actually just, what if we help her with eating some more energy-dense foods? Same exact strategies, but just targeting a different aspect of her health that we're worried about. So they did that. And in the end, treatment with this family lasted 6 months and 17 sessions. And by the end, Allison had really expanded the variety of foods that she was able to eat. So she started off with only one specific brand of mozzarella string cheese, and by the end she could eat any white cheese, any brand, any form of it. It doesn't have to be like string cheese. She started off only eating pasta with butter, and by the end could eat pasta with any type of sauce. She also became okay with grill marks. So that was a big milestone for her, and she started to eat some fruits and vegetables. The most important thing, or one of the more important things too, was that even though that they had taken a long time to really intentionally target helping her eat more, a family was able to help Allison gain weight and grow over the course of their time in this treatment. So that was pretty exciting. When Allison finished treatment, she was not like the world's most adventurous eater. She was still not eating a ton of fruits and vegetables, but she was eating much more flexibly than she was before, particularly able to participate in her, like a normal 9-year-old social life again. But kind of the biggest takeaway for the family was that this was something that they felt able to continue helping Allison with after, on their own. They could kind of be their own therapist. So thank you. That's it.
We are going to introduce Dr. Jennifer Doreen, who's going to help and facilitate our question and answer part of this session. Dr. Doreen is a clinical professor in child and adolescent psychiatry, and she's also the psychiatric director for the Comprehensive Care Unit, which is our inpatient eating disorder program. So we wanted we're going to have some time for questions and answers, but we also wanted to take a few minutes just to tell you about some of the resources that are here at Stanford. Yeah, all right.
Well, thank you, Dr. Kapan, for that. I have, I think, the easiest part of the evening, which is to facilitate a Q&A, and I want to thank you all for such wonderful talks. I'm very privileged to work with these amazing clinicians and researchers on a regular basis. We wanted to introduce you a little bit to the services we have available here at Packard. The comprehensive care program is actually our inpatient unit. As Dr. Kapan mentioned, I'm the psychiatric director. She's the medical director. And we have 15 beds that are completely devoted to inpatient treatment of young people who are medically unstable as a result of malnutrition. And often this is related to typical eating disorders like anorexia nervosa or bulimia nervosa, but we also see a fair number of young people who have ARVID or become malnourished for other reasons, sometimes medical reasons, sometimes untreated depression or really severe anxiety that presents itself with difficulty eating. We consider ourselves a very supportive, and we are certainly a multidisciplinary environment. We offer a variety of therapeutic modalities. It's milieu-based, which means that it's not just young people in a hospital room having their meals and snacks in their beds. We actually have groups. We have a dining room where they're able to eat meals with other patients, but we also very much encourage families to come and for them to have meals together on the unit so that they can practice some of the strategies that they'll want to take with them when they go home. And we definitely incorporate a family-centered model of care. We have a health educator, we have a parent education and support program, including parent education and support groups that happen on the weekends. And in order for people to get to our unit, they must be medically unstable as a result of malnutrition. And to leave the unit, they have to be medically stabilized. So unfortunately, we can't admit people just because they're having trouble with some of the eating disorder behaviors that are very common, but they actually have to have some of the medical instabilities associated with malnutrition. Here are some photos of our space. I think, we at times wish that we could be here on main campus, but we also recognize that we have a really lovely space over at El Camino Hospital in Mountain View. And we have a picture of our activity room, our school room. We actually have a really lovely outside terrace, which is kind of unusual for units like ours. And the phone number is here in the event that anyone is looking for some referrals or resources.
99% of the treatment takes place outpatient. About 1% of the time we have treatment is in the inpatient setting. And in the outpatient setting where Kim and I work, and I used to do what Jen does now, but it's a evidence-based intervention program for all eating disorders, and we have probably I would say, the most talented group of psychologists that is around to treat eating disorders anywhere. I would challenge anyone to find a better group.
For kids that come into our program, They have a very full assessment with nutrition and adolescent medicine and psychiatry. And then it can either be on a one-time basis with input about what would be helpful for that individual, or it can be to establish ongoing care with psychiatry or with adolescent medicine or with both.
Thank you for coming. Thank you again to the speakers, and we hope you all have a lovely evening.
Yes, thank you.